So excellent. That was a wonderful film by Maya. Esther, we're so happy to have you with us today. Dr. Esther Tailfeathers was born and raised on the Blood Tribe Kainai First Nation in southern Alberta. She graduated from the University of North Dakota School of Medicine and completed her family medicine residency at the University of Alberta. Esther has worked with many First Nations, among them the Emergency Department of the Blackfeet Reserve in Montana, the Blood Tribe Reserve for almost 20 years, and in North Alberta community of Fort Chipewyan. She's most proud of organizing a relief mission to Haiti after the earthquake in 2010, leading a team made up of Blood Tribe paramedics, nurses, and healthcare workers who took care of more than 2,000 patients during their relief efforts. Most recently, Dr. Tailfeather has focused on the Blood Tribe's response to the opioid crisis, including harm reduction and treatment, and addressing the upstream determinants of health. Dr. Tailfeathers is currently the Senior Medical Director, Provincial Indigenous Wellness Corps at the Alberta Health Services. Thank you so much for your time here today, Dr. Tailfeathers, and we look forward to your presentation.
Thank you, Annalise. Hello, everybody. Welcome to Blackfoot territory. I'm sitting at the very southern end of the Blood Reserve, which is part of the Blackfoot Confederacy. That includes on the Canadian side, Siksika, which is east of Calgary, Bigunny, which is around Pincher Creek, Kainai, Organa, and then the largest tribe of us is on the Montana side, which is a Blackfeet tribe in Montana. So welcome to this area. Also, I would like to acknowledge the new forged urban Indigenous communities in Lethbridge and some of our smaller places in the Métis Nation of Alberta. Thank you very much for inviting me today, everyone. I don't have a PowerPoint. I thought maybe I could just take it story-wise. I know the lunch hour can go very fast. So I just want to present what's happened to Blood Reserve over the period of time starting in 2014, when we started noticing a greater number of overdose deaths. And I don't know if anybody's heard my talk before, but the very first fentanyl overdose that I did experience was in the parking lot at Walmart, and it was a very young man from one of our Confederacy reserves. He was in his early 20s. I pulled into the Walmart parking lot, and there were 3 children in the vehicle, and I heard them screaming. When I turned the car off, I looked and I saw the individual fall out of his vehicle, and when I went to go check, he wasn't breathing and he had no heartbeat. And for a young individual in the young 20s, that's, it's hard to determine what would cause that other than an overdose. Luckily, his life was saved. And after that incident, we began to see more and more overdoses. Many of them, we were not certain what the substance was, and so we finally added fentanyl to our talk screens within the emergency rooms, and lo and behold, fentanyl was in every one of the overdoses. So we did mobilize Blood Reserve, and we started talking about harm reduction, and we had some very good help from, at that time it was Lethbridge HIV, and Stacy Burke and the team that worked there suggested that we start naloxone, teaching our people on the reserve how to use naloxone and save lives. Nowhere else in Alberta did they do that except in Edmonton with Streets Alive, where they taught lay people how to use life-saving drugs in naloxone. So we did, Stacy and her team went to BC. They learned a program called, no, I can't remember. It's like teach the, it's been a while, but it's like teach people, and then they will teach others. So anyway, they went and learned the program. They brought it to Blood Reserve. we did a reserve-wide blitz in a lot of our communities and distributed naloxone, which was unheard of at the time. And Health Canada was very helpful, or a couple of the doctors from Health Canada. But when it was heard in Ottawa that that we were using naloxone by lay people, it was stopped, and the individuals were basically punished for the work that they did on harm reduction. Later on, our chief did write a letter and say it's very important that we save lives here. And we were able to start with the legal process of harm reduction on our reserve. So in March of 2015, we had experienced up to 20 deaths from fentanyl overdose and mixed overdose. And when people started using naloxone, for 3 months we had 0 deaths. So we empowered our people to be able to save lives and recognize that they could save a loved one within their home. So we began to work on a continuum of care to address the addictions within our community. One of the best things that we could have done was that we made a trip to Vancouver to visit the Portland Housing Society, the downtown east side, and as you see in Elamaya's movie, we brought a group of women there to learn about harm reduction, about safe consumption, about something called Intox and Insight, and Opsite, and Insight, Opsite, and then there was things like Spikes on Bikes, where you see a segment there where there are individuals who have naloxone in their fanny packs and all of the life-saving and harm reduction equipment, and they bicycle around the downtown east side and save lives. So there are very many life-saving measures that are taken in Vancouver in the downtown east side. So we brought some of our learnings back. We started opiate replacement therapy, which is now well accepted all across Canada. We started with buprenorphine, naloxone, oral ingestion, which required a triplicate prescription and was very controlled. There were very few of our family physicians or our doctors who were prescribing at the time, so it was quite exciting, but also a very heavy load when there are very few physicians who prescribe Suboxone. We then added methadone, and we do have methadone prescribers now in our clinic. We actually have an addictions clinic, walk-in clinic every Wednesday. We went on to start talking about treatment, and it's very important to understand that at the time a lot of our people were overdosing. The Alberta Health Services opened up many sites or spots for our people across the province and welcomed us into the treatment centers. But most of the treatment centers that we sent our people to were abstinence-based treatment, and they were not withdrawn enough. They were still sick when they arrived at the abstinence-based treatment centers, and as a result, many of them didn't finish the course of the abstinence-based treatment. Many returned to the reserve and used at the dose they were using or the amount they thought they were using when they left. As a result, we had more deaths and more overdoses. So we recognize that abstinence-based treatment did not work for our people. So we have to start working on more humane ways of helping people to withdraw and also to be treated so that they don't feel like failures. When they go through abstinence-based treatment, they do feel like failures. And in Maya's movie, you will see that that happens a lot. There's a lot of falls along the way, and recovery is never from A to B to C to D. It's often A to B and then back to A again. So we're recognizing that we need to support them and not make them feel like failures in their recovery. The most significant and exciting thing that I think we have done on our journey is to develop a detox center. It's called Bringing the Spirits Home, and it's medical detox, and we partnered with the EMS paramedics on the Blood Reserve. We've built our program. We were supported previously by the NDP government, Sarah Hoffman, who took a chance on us and gave us our initial grant to open our detox. And it was initially for 8 people and grew to 21 people. And the current government also supported us with funding for our detox. So instead of our people going to emergency rooms when they overdose, the ambulance diverts them straight to detox. We have an observation room where we allow, or we have fluids, so they're resuscitated with IV fluids. We give mild sedation, usually Ativan, or if they're really having a tough time, stronger sedation, so they can get through the first 12 to 24 hours without going through the nightmare of all of the symptoms of withdrawal. So when they start feeling better and they're able to eat and they're able to sleep, and we're able to initiate opiate replacement therapy, then we do, and we invite them to stay, and we try to keep them there until they get into treatment. And therefore they don't have the opportunity to relapse from the detox that they've done. And some people will stay, somewhere from 3 weeks to 3 months to 6 months, to get them into the appropriate treatment facility in Alberta. And on reserve, we have the Kainai Healing Lodge. Some of the really good things that have happened at our detox is that we don't separate. When a woman comes in pregnant, we support her through her pregnancy. We try to decrease. We try to make them comfortable first, get them through their initial withdrawal, get them stabilized on either Suboxone or methadone, and supportive medication for any other substances that they're withdrawing from. And then we try to decrease the Suboxone or methadone to a reasonable amount so that when they go in to deliver the baby, that the baby does not go through severe withdrawal. And it's called neonatal abstinence syndrome. So by doing this, and one of our staff members will accompany the mother to her delivery. So always there is somebody supervising or helping and supporting the mom. So we prevent the apprehension of the baby by child welfare. We try to keep the bond between mom and baby stable, and we return them back to the detox center as a unit, a mom and baby unit. And so we've had 4 successful interventions like that, where the mothers have now gone on to have their own home, never lost custody of their baby, and are putting their lives back together. So I think the baby that you see me holding is one of those babies that stayed with mother, and mother was able to keep her children. So these are some of the things that we've done with our continuum of care. You might ask why this and how this happened. So most of us were quite shocked and couldn't understand the 215 children or the remains of the 215 children in Kamloops. And why I'm saying that is because one of the most traumatic, long happening events to Indigenous people across the country was residential school. And we know, and if you've heard Gabor Mate give his talks, you know that trauma is a major part of addiction. And when you take a look at residential school, and you start counting the number of, or the type of trauma that children have had, there is also, I want to stop there and say that there is a study that was done by Kaiser Permanente. It's an HMO in the States, and they tried to figure out chronic disease and what was the association between chronic disease and childhood trauma. And they came up with what's called an ACEs score, Adverse Childhood Event Score. So for everything that a child has experienced, whether it be physical abuse, emotional abuse, sexual abuse, abandonment, a number of adverse events. Many of the children that went to residential school received almost all of those adverse childhood events. And as a result, many of those who are survivors actually have high rates of addictions. So we know that adverse childhood events and the trauma in residential school does affect Indigenous people across the country, and that's one of the reasons why we're seeing such high rates of addictions, especially now. Poverty is the second biggest one, and I know in Saskatoon, Leemstra and Neudorf did a study on poverty within neighborhoods, and they were able to distinguish that the neighborhoods, the lower and lowest income neighborhoods, are the ones with the highest prevalence of chronic disease and addictions. And we know that historic Canadian policy has put Indigenous First Nations communities and Métis communities in a situation where they're in abject poverty, and it's very difficult to even address housing situations. And finally, the social determinants of health. And one of the ones that we see today, which is pretty significant in this south zone of Alberta, is racism and how people are treated and how difficult it is to get the services they need to address the addictions that they have. So I don't want to make this completely a talk about victimization. I want to let you know that there is resilience within the people here, and as we speak, Blood Reserve has reignited its task force, and so at that table on Tuesdays and Thursdays, after everybody's work is done, we sit down and start looking at strategies to help our people. So it's policing, it's social development, it's child welfare, it's detox, it's EMS. So we all sit down together and try to figure out the best way to address situations and come up with a strategy. And it's wonderful to see the people around that table who are working hard within the community to address a community issue. I think I'm going to leave it at that. And I think what we wanted to do is have some discussion. So I'm going to open it up to discussion. And if Annalise, you want to lead the discussion?
Yeah, excellent. Actually, if I'm going to exercise my moderator privileges and ask the first question, you mentioned that all the spaces are dry or are, you know, you have the abstinence spaces. What would a space look like if it wasn't? What would that look like? How would people be supported there?
Well, I think that one is the expectation, and it's in Elemiah's film, but the expectation is that somebody goes from, using heavily or being heavily addicted to becoming completely clean and sober. And, that would be one of the old expectations, and something that we used to dwell on, and that's the 12-step program and expecting complete abstinence, which is the goal. That would be like the golden rule, or the golden place, is to be completely abstinent and happy. But through our experience, we know that many people cannot go from A to D and walk out and be completely healthy. We know through experience, especially with the detox, that people may try 2 or 3 times before they actually really begin to heal, and they do need lots of support, family support, or a partner who is, very supportive. So we know that the abstinence-based treatment has very high expectations of people, and one of the things that's very human is the feeling of failure when you cannot achieve what other people expect of you. And so I think it's very important that our treatment centers address abstinence-based treatment, and that it actually can be harmful in some ways by the expectations that they're giving to people, that they will leave these places completely clean and sober and their lives will be great. It doesn't happen that way, and we're finding that out.
It feels more like a fairy tale, that from A to D, right? Yeah.
Yes, that's true.
Yeah. Next question is from Knut Peterson. Thank you very much, Esther, for speaking to SACPA on very short notice. Can you please describe more details on how you were affected on the blood reserve when the SCC in Lethbridge was closed, when Arches was closed?
We were heavily affected. And of course, COVID happened just shortly thereabout. One is there were no safe places for our people to be. So our membership, we lost 91 people, more than what we did in the beginning of this crisis. And many of them were found in back alleys, behind houses, or in basements alone. And so we had a very high mortality rate as a result of the closure of the safe consumption site, or the of the safe consumption site, or SCS. And also there was a really ugly period for our people where there was what I call social pornography. And on YouTube, there were many people who were posting videos of our people in struggle, many who were in the throes of being in really rough shape, and they were being posted on YouTube, and YouTube was sharing pictures of somebody in a sick, very sick state with no help, and this became a very racist event, and our people are still reeling from that. The racism has only grown in Lethbridge and gotten worse. It has not gotten better. And you will hear many of our people will not go to the emergency rooms. They will not go to the clinics. In fact, there are no openings for a lot of our homeless people in the inner city of Lethbridge to have a primary care physician. They just are not allowed into the clinics, or the clinics are not accepting new patients, but especially not patients with so many difficulties. So it has impacted us heavily in two ways. One is mortality, and the other is we're dealing with a greater issue of racism than we ever had before.
Our next question comes from Timothy from the Lethbridge Herald, reporter from the Lethbridge Herald. Last week, Elder Rogers Prairie Chicken said that the true extent of the overdose problem on the blood reserve is being underreported, if anything, according to the statistics he compiled. Your thoughts on that, please?
Oh, I have good thoughts on that one. I'm very angry about that post that was made in the Lethbridge Herald. I was not called by Timothy or anybody else to corroborate the claims that were made. I think that those individuals in a time of pain were taken advantage of, and I call this social porn. We were centerfold and front page for Lethbridge Herald, and there was no corroboration for that story. I was not called. I was told I would be arrested if I went to that site to make a statement. I would like to say that our people have worked very, very hard on a strategy to overcome what is coming on. I did not see any verification of the numbers that the Lethbridge Herald posted. I think it's very shameful of you, Tim, to have done that without corroborating the story with other people on the reserve who are working very hard. In fact, that story has divided our community, and we are now working with that pain.
Our next question comes from Laurie Schultz. Would you comment further on the treatment options available to your community? Must residents leave? What are the gaps? And finally, what treatment model would you believe to be effective?
I think that the harm reduction treatment model is probably the most effective way of dealing with people. I think that wraparound supports are very important, including housing alternatives. And for people to recognize that addictions are not, like I said, they're not from A to D. And I think that we need to have more trauma-informed care in the work we do with all people with addictions, not just Indigenous people with addictions. We recognize that many children and many people who are dealing with addictions have had many really difficult events in their lives. And perhaps we need to look at those within our treatment alternatives as well.
Our next question comes from Ian Hurdle. I'll start again. We are almost a generation since the last residential school closed. As time goes on, do you think this distance will help the next generation?
I think it will. I think what we have to do is understand. We need to understand where this is coming from. I think the blaming the victim, it has got to stop. I mean, it's not going to change the way people are. And I think one of the things that we must understand too is something that's called return on investment. And I hear that a lot within Alberta Health Services. And that is what good we do and how we strategize on the front end of a problem will result in the return in investment. That means we're hoping to see less people going to the emergency room. We're hoping to see less burden on the ambulance and police, less burden on the community in terms of the crime rate. So if we address this properly, I think that we will see a return in investment, and hopefully within the next 10 years. But it won't happen until we address this the way it needs to be addressed. And part of it is listening to the people with addictions and lived experience.
I would like to ask another question, Esther, if that's okay. What about this new scientific thought about genetic trauma that is genetically inherent? How does that? Do you have any thoughts on that? I know the University of Lethbridge is looking into that right now. I'm just curious if you knew more about it and could share that with us.
Yeah, I think the study of epigenetics is very important. I know that there was a wonderful physician, Dr. I think his name was Dr. Mustard, who did study childhood trauma. I think he went to Cuba and did a lot of work in Cuba in terms of how early childhood was, and also on epigenetics and how the environment that an infant or a fetus is like the environment that the fetus is in does help to or it does affect how certain genes are expressed. And so I think that when a mother is stressed, when she's hungry, when she's afraid, if she's been, assaulted, there's so many things that affect the hormones of the mom, which may be affecting the development or the expression of genes within the fetus or the infant. And my mother used to say to me, and I used to think it was crazy, but she said to me, when a child was born with a birthmark in a certain place, she would say, well, the mother has been hit or the mother has been hurt, and it's coming out in the birthmark that the child has. And I mean, it literally maybe is not that way, but it is metaphorically the same thing, I think.
Our next question comes from Mark Goodall. Do you think that decriminalization of illicit drugs is a good idea? Would this help or exasperate the situation?
I think in our situation here on Blood Reserve, what we understand is that there was a market that was built on prescription drugs and illicit alcohol. Our reserve is still under the Indian Act. We're still a dry reserve, which means that we cannot legally sell or have liquor on the reserve. As a result, people will buy, and in the town of Cardston there is no liquor store, and there is no legal place to buy alcohol in Cardston. So many of the people who are alcoholics or addicted to alcohol will buy hairspray and mouthwash, which is very damaging. And you'll see that in Maya's film as well, that we really need to look at managed alcohol programs, which would help reduce head injuries and GI bleeds and cirrhosis. And that's with regard to alcohol. With regard to drugs and illicit drugs, we know that there was an illicit prescription drug market prior to the entry of fentanyl. And so what happened is people in poverty, even grandmothers, many times would give their prescription drugs, which were Tylenol 3s or other opiate prescription drugs, to family members to sell so they could buy groceries. So out of poverty was a market that grew, a black market for prescription drugs. And we know that when Neo-Oxy came out, there was a period that people were not able to get legal prescription drugs and not use it in the ways that had progressed to injection or snorting. And as soon as fentanyl arrived on the scene, fentanyl replaced and was one of the commodities that this drug market had already had, or these dealers already had. They just plugged in fentanyl and they made lots more money, and there were lots of deaths. So I think that a very supervised and controlled safe drug supply would help decriminalize drugs. I mean, decriminalize drugs would help because we would see less harm to the individual. As we know, and we're seeing now, is a broader use of street drugs. So it initiated with Tylenol 3s, it grew to other things, and then fentanyl. And now we are treating fentanyl, carfentanil, heroin, and crystal meth. And as we know, meth is does not have a replacement, so we have to use supportive medication. So it's only getting worse. The amount of poisons that are within the marketable commodity is changing, and it's worse. We're seeing benzodiazepines as well, which cannot be reversed on the scene. So even though they have naloxone on the scene, they're still not able to revive people with the other substances in that. So Portugal has done a very good job of safe supply, and I really think that in order to decrease the criminal element and safely bring people to the possibility of going to detox, the possibility of getting into treatment, is to make it safer for them and make it easier for them to get the help they need.
Our next question comes from Laurie Schultz. Is your community continuing to collaborate with other agencies such as the HIV Lethbridge Group or others?
Yes, we're reaching out to work with the urban Indigenous groups. We work now with the Indigenous Recovery Coaches Program. We work with Mark Braverock with the Sage Clan, and we were working with the Friendship Center. I think they're in transition, so we work with the Friendship Center as well, reaching out to those people who are our members but live in Lethbridge and supporting other Indigenous members. And then there are many ally groups, I think, that we will work with, but initially we're working with what's going on in our community, and then we're working out from there.
Our next question is from Knut Peterson. Brian Culp, let me just turn this off, sorry about that. Brian Culp at the University of Lethbridge did a lot of work on generational trauma. Question: at this point, which level of government are or can be most helpful, provincially or federally?
I think that thank you, Brian, for that question, and thank you for being my professor in pre-med. But
the question
yes.
was from Knut Peterson. Sorry.
Oh, it was from Knut. Okay,
Yeah.
so Knut, yes, Brian Kolb's done a lot of work on intergenerational trauma. I think we have to go to all levels of government and all levels of community. I think that we need to educate as many people as possible on what the problem really is and where can we strategize in terms of projects. Which government has what responsibilities. So, and I thank you for the opportunity to speak to you this afternoon, because I think it's very important that we work together in understanding this problem. But things like, if the project is a federal project for housing, then we need to apply for those projects from the federal government. If the project is addictions and mental health within the Alberta government or AHS or any of the non-profit societies that also have programs and projects, I think we need to address, or we need to propose strategies to them as well, so that we can all be involved in a collaborative strategy to address, number one, trauma, number two, poverty and social determinants. And one of the biggest problems right now is housing. We have a growing population of homeless people, both Indigenous and non-Indigenous, and housing alternatives. I think beyond the 3-bedroom bungalow, there's a lot of alternatives for supporting people who need to get into homes. Thanks, Knut.
Our next question comes from Mary Claire Greenshields. Thank you for sharing your knowledge, Dr. Tailfeathers. Dr. Matei's most recent film suggests that we must approach trauma with willingness to be vulnerable and compassionate. Any ideas how we can encourage this?
I think one, I'm just writing that down. I love Dr. Matei's thinking and the work that he's done. He's helped a lot of people. But it's very difficult for Indigenous people to become vulnerable when they're taken advantage of, like the Lethbridge Herald did to a number of individuals in a very, very difficult time. So I'd like to warn people that most Indigenous people are afraid to be vulnerable in front of non-Indigenous, because they're afraid that it gives a platform for racism, and it gives a platform to drive that whole stigma home about how Indigenous people are not equal to non-Indigenous people. So I caution you to be very, very careful about the vulnerabilities that people show, and show kindness and compassion back to the vulnerability, rather than driving the point home that Indigenous people are not equal and are victims of their own on their own accord.
Our next question is from Laurie Schultz. What measures would you like to see established to deal with contributing factors such as poverty, etc.?
I think that the Canadian population doesn't understand that, and I'm not aiming this at you, Laurie, but that the Canadian population does not understand that there are policies under the Indian Act which do not allow us even to have mortgages on the reserve. They do not allow, at one time within the Blood Reserve, there was a paper that was written by R.N. Wilson that said we were not able to buy or sell hay. We were not able to buy or sell cows or horses without Ottawa's permission. As a result, one winter, most of our cattle froze because Ottawa did not, they did not okay it, and it took forever to get there by train. By the time the request got to Ottawa, the cattle were already dead. So it's a historical policy that we need to look at those policies that cause poverty one of them being housing. The housing policies of not being able to get a mortgage have created the situation that we have today, and that is people unable to buy their own homes on reserve and be reliant on a government housing program. Many things. I applaud what's happening with a lot of our educational institutions in Alberta, because they are uplifting the education of Indigenous people within U of A, U of C, U of L, and many of our community colleges, and I think that is the right move to take.
Our next question, sorry, I'm lost in the thread here. Our next question is from Mary Shillington. As a retired social worker, I'm wondering how you and other professionals are working at keeping yourself positive when there are so many issues you're trying to deal with.
That's a difficult question to answer, because we're always on the go in terms of trying to strategize and help people within the community. And I think it's probably being part of a communal culture where you know that one action that you take may affect 10 other people in the community. And as difficult as it is to continue with the energy and the giving that needs to be done, there's only one way to beat the inequities that we face today, and that is to work even harder. And so many of our frontline workers are very tired, but we recognize that the need is there for us to do that. So when COVID is over, I'm sure many people will be really happy to take a break. And when we start to see our numbers decrease in terms of overdoses and the morbidity as well as the mortality, I think then we can start taking a break.
Our next question comes from Laura Schultz. What actions can the Southern Alberta community as a whole and individuals take towards a solution?
I think the main thing is to understand what is colonialism and what is settlerism. I think we all need to understand that we are all treaty people. We may not have all signed that treaty, but there were parties to that treaty, which were the Indigenous and treaty people and the settlers, and we all have a responsibility to maintain the peace and to recognize each other as equals, not unequal. And I think one of the things that we really have to work on right now is addressing racism in Southern Alberta, because it affects people's housing. People cannot get into apartments or homes. It affects employment. It affects education. It affects childcare. Racism affects every avenue of an Indigenous person's life.
We got Timothy from the Lethbridge Herald, who argues that he would like to clarify the Herald was called by organizers of the event who are Indigenous elders, and we did reach out to the Blood Tribe Department of Health. We got no comment.
Well, Tim, you were involved in a situation where there should be privacy for the employer and the employed. This is not any business of the Lethbridge Herald. This is the business of the employer and the person who was employed. And by doing what you did, you drove a wedge into the community. And a responsible journalist would look out for the well-being of the person that you are interviewing and make sure that they are safe. Many of those people are now in an unsafe place because of the irresponsible reporting that you did. I did not receive a call. I was told that I would get arrested if I came down to speak to the press. So were many of the people from Blood Tribe Department of Health. So really, if you are a responsible journalist, you would have saw this situation and you would have got and waited and thought about the well-being of the person, the people that you exposed. Very wrong.
Our next question comes from Ian Hurdle. if the funding that the Supreme Court said was not given to Indigenous community was supplied, how much would this help?
Sorry, can you repeat the question?
Yeah. If the funding that the Supreme Court said was not given to Indigenous communities was in fact supplied, how much would that have helped?
In terms of safe supply? Or in terms of treatment and detox?
Ian, could you clarify that? Could you please clarify your question further? What funding are you addressing here when you're saying the Supreme Court? We'll just, so we'll just wait for Ian's question. While there's no other questions in the queue, so I'm just curious, what would be, like, in terms of your best case scenario, what would be your Ian just answered welfare and health, so let's go with that. So I'll read that question out again. If the funding that the Supreme Court said was not given to the Indigenous community was supplied, and he says welfare and health, how much would this have helped?
In the 1800s, it probably would have helped a lot. But I think the framing of funding and the narrative that is taken in funding that is supportive of Indigenous populations needs to be framed in terms of, number one, welfare is probably one of the most damaging things to Indigenous people across the country, because we became more dependent. So the framing of that should be employment initiatives, housing initiatives that are not just welfare. And I understand that you meant well by that, Ian, but I think that we really need to take a look at what is the narrative of that funding? Is that funding supportive in terms of people becoming independent or rather dependent? So one of the greatest damages to our people was welfare, and it's really, really hard to get away from dependency thinking. And so definitely health would have been one, and also the provincial governments working with the federal governments to lift jurisdictional barriers for hospitals, detox. Many of the services that are provided by Alberta, sometimes they're replicated by the federal government on reserve. So sometimes we have dual programs going in certain places, but no programs going or no services going. So for the detox, because of the way that the Constitution is written, detox cannot be built on reserve, and they cannot be supported by federal government. And so Sarah Hoffman took a big chance in terms of supporting us with a detox, because the provincial government is not to fund detox on reserve, and neither does the federal government. So the chance they took has really helped. And so we need to look at lifting some jurisdictional barriers when it comes to healthcare.
Our next question comes from Clint Peterson. Are you optimistic that present educational opportunities for Indigenous youth in its present form, both K-12 and post-secondary, is adequate or just a good start?
I think it's getting better. Number one, I want to say that it's very, very important that we keep residential schools and the harm of residential schools in our educational curriculum, so everybody understands the damage that residential schools does to human beings. So that's very important. But I'm very optimistic about education itself. I just read yesterday that we have an 8th student going into medicine from the Blood Reserve. So when she's done, we will have graduated 8 doctors from our community. And I'm seeing posts all across Facebook of all of the young people who are graduating. and they're more aware of what really needs to be done for their communities and how they can contribute to not only their communities but to changing the Canadian picture. So I'm very optimistic about education.
Which brings us into Laurie Schultz's question. Could you discuss methods and models of educating non-Indigenous people as to history and truth and reconciliation?
I think that one is we need to start as young as we can, with a shared curriculum on, what is a reserve. My sister is a teacher here in Cardston, and she's teaching 8th grade. And none of the non-Indigenous students in her class know what a reserve is. They do not know which reserve they're located next to. They do not know what a treaty is, and they've never heard of residential school. I was shocked. So I think that we need to start as early as possible in educating non-Indigenous people on the history of Canada and the history of Indigenous people. I think that will help in the understanding and the lights that go off in children's minds on how they can contribute, because children are very, very innovative. But through every step of the way, truth and reconciliation means first truths. I really see that certain media can carry the stigma of racism and continue to take a hammer and hit Indigenous people over the head with the same stigma, which helps to lift racism and continue to propagate the stigmas that many Canadians have about Indigenous people and other races. So media, I think, is to blame for continuing to propagate the stigma, and they really need to question the narrative they have when they talk about Indigenous people. Is it from a narrative of strength or a narrative of victimization, and do they continue to victimize? And so I think that truth needs to be told from a narrative that people understand, and not a continuous narrative of, they're, not smart enough, they're not good enough, they did this to themselves. So the truth really needs to be told, and I think over the next few months we will be hearing about more and more graves that are found, and we will understand more and more of what, horror many children went through and why many people have addictions. Reconciliation, I think, means allies listening, learning, and supporting. I think the return on investment of truth and reconciliation, hopefully in the next 10 to 20 years, shows that we'll have a less burdened healthcare system, and and people will be happier about the outcomes that we're seeing.
Thank you so much, Esther, for your time today. I would like to read out a couple of thank yous that are in the queue. Laurie Schultz, Dr. Till Feathers, heartfelt thank you for your time and presentation this afternoon. Mary Claire Greenshields, thank you so much. Amazing presentation. Ian Hurdle, nice to see Maya all grown up. Knut Peterson, much appreciated, Esther, that you took time out of your busy day to talk here. And on behalf of SACPA, we very much appreciate your time. And on this very emotional topic, would you, before we end the session today, could you give us a take-home message? I think your last question already on truth and reconciliation was very powerful. Your whole talk's been very powerful. But do you have a take-home message for us today?
I think that I'm very thankful for this opportunity to speak to you and the platform to help teach what's really happening here. But I'm very optimistic that the more we have these kind of discussions, the better things will get for all of us. And talking sometimes is difficult, and sometimes it's awkward, and sometimes it's painful. but I think we're going to get to another place, and I really see that with this kind of work that you're doing, that we will lift all of us to a different place.
Thank you so much.
Thank you, everyone.
Thank you. And for our viewers, please join us on Thursday, An Educator's Perspective on Alberta's Proposed Draft Curriculum with Cam Rogers and Kelly Freewin. And also join us again on Monday, June 21st, for a special session with Keith Moon, The Deadly Effects of Residential Schools in Canada. What can we do now? So we look forward to you joining in then. Okay.
Thank you.